Welcome to this week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMEDPRN. And for PRN members, slides can be found under the Library Entries section of the ACCP Communities website.
Today, I'm excited to talk to you about the Argatroban in patients with acute ischemic stroke with early neurological deterioration. By the end of this presentation, my goal is for the audience to describe the presentation and assessment of early neurological deterioration, or END, following acute ischemic stroke. We'll also review the role of antithrombotic therapy in acute ischemic stroke, and we'll discuss a new study. As Margaret has touched on earlier, acute ischemic stroke is a sustained lack of blood supply to an area of the brain, leading to cell death and neurological deficit. There's multiple ways to assess a neurological deficit using the NIH stroke scale, SSS, MRS, or aspect scales. It is definitely associated with high morbidity rates. She also touched on there's 5 different types of acute ischemic stroke. You can see on the table here, as well as with the frequency of each type of stroke. So the most common one is definitely cardioembolic stroke at 30.2%, followed by small vessel occlusion at 25.8%, and followed by large artery atherosclerosis at 15.3%. I won't go over this too detailed, but the National Institute of Health Stroke Scale is one of the most commonly used stroke scale in order to assess this severity. So the scale goes from 0 to 42, with minor stroke going from 1 to 4 and moderate going to 5 to 15, and moderate to severe 16 to 20. Early neurological deterioration, or END, is a common event, roughly 24% following acute ischemic stroke, associated with severe prognosis. The definition of END definitely varies depending on which study you look at. I have 4 studies cited for you here. What I want to get out of this is that the point of increase in the NIH stroke scale can go from 1 to 4 depending on the trial, and the time of assessment also depends on the study. So it goes from 48 to 72 hours, can up to 7 days. Looking at our current guidelines from 2019 for early management of patients with acute ischemic stroke, Margaret already touched on thrombolytics. So currently, IV alteplase is recommended for selected patients with the risk of potential incomplete recanalization and the risk of hemorrhagic stroke. Mechanical thrombectomy is also recommended in very selected patients. What I'm going to focus on today is the use of anticoagulants. So urgent anticoagulation with the goal of preventing early recurrent stroke, halting neurological worsening, or END, is currently not recommended. And this is coming from the 3 landmark trials that we've had in the past. So the first study was the ISD study in 1997, roughly 18,000 patients, the TOAST study in 1998 with roughly 1,200 patients, and the TASTE study in 2001 of roughly 1,500 patients. Each of these studies looked into a very specific type of anticoagulant compared to aspirin or compared to placebo. What I want to point out is that most of these studies, whether their primary outcome was death within 14 days or favorable outcomes from a functional standpoint, or MRS score of 0 to 2 at 6 months, there was no statistically significant difference in the primary outcome. However, what we do see is a statistically significant increase in hemorrhagic stroke in the ISD study, or serious bleeding in the TOAST study, or symptomatic intracranial hemorrhage in the TASTE study. Some other anticoagulants that have not been as heavily investigated, including Argatroban, dabigatran, or other thrombin inhibitors for the treatment of patients with AIS, is not well established. So what is Argatroban? It is essentially a direct, highly selective thrombin inhibitor. It reversibly binds to the active thrombin site of free and clot-associated thrombin. The half-life of Argatroban is a little bit more favorable at only 39 to 51 minutes, which can be prolonged in hepatic impairment of up to 3 hours. The key indication is listed here, and the dosing is per the package insert. One of the more commonly used for Argatroban is PCI. We can also see the use in heparin-induced thrombocytopenia. Depending on the institution, at our current institution, we titrate Argatroban to the APTT, and our range is roughly 55 to 90. Now I want to introduce you to some of the key studies that investigated Argatroban in acute ischemic stroke. The first two studies by Barreto in 2012 and the ARCS-2 study in 2017 looked at patients who had thrombolytic therapy, which will be different from the next two studies that we're going to be discussing. What I want to point out from these two studies is the differences in dosing. So the first study used Argatroban 100 micrograms per kilogram bolus, followed by 1 mics per kilograms per minute for 48 hours. The second studies looked at two different dosing of low-dose Argatroban, which is similar to the first study, but they also looked at high-dose Argatroban of 3 mics per kilograms per minute. The ARCS-2 study did exclude planned endovascular therapy. Overall, they saw that patients had non-statistically significant better functional outcomes at 90 days with not a lot of ICH. In fact, in the second study, there was only 10% in both groups. The next two studies were by Zhu in 2020 of roughly 500 patients, and the lead study in 2022 was 650 patients. These two studies looked at patients without thrombolytics. So these two studies looked at patients without thrombolytics, and they were comparing dual antiplatelet therapy plus Argatroban. You can also see the very different dosing in these two studies. The first studies had a very fixed dosing at 60 milligrams per day for 2 days, then 20 to 30 milligrams per day for 2 to 5 days. The second studies also used the dosing from the previous two studies that I mentioned, where it's weight-based at 100 mics per kilograms bolus, and then followed by the infusion of 1 mics per kilograms per minute. It's important to note that the definition of END in these studies were a little bit different. So the first study looked at increase of 2 points in the stroke scale at 7 days, and the second study looked at increase of 1 point in the NIH stroke scale at day 7. First study found that patients who were on DAPT plus Argatroban had fewer END occurrence compared to patients on DAPT by itself. The second study also found significantly higher amounts of patients who were on DAPT and Argatroban with less END occurrence compared to DAPT by itself, and there were no ICH found in both studies. This leads to our current study, which is Argatroban in patients with acute ischemic stroke with END, which is a randomized clinical trial. This was a prospective, multi-center, open-label, but blinded endpoint randomized study that took place from April 4th, 2020 to July 31st, 2022 in China. Both groups would receive standard of care, including mono or dual antiplatelet therapy. According to the Chinese 2019 acute ischemic stroke guidelines, aspirin is recommended for patients with acute ischemic stroke within 24 to 48 hours, but clopidogrel 75 milligrams per day can also be used as a primary antiplatelet drug therapy. For patients who were not eligible to receive IV thrombolytic, then dual antiplatelet therapy would be recommended. In the Argatroban group, they would receive standard of care in addition to Argatroban 60 milligrams per day for 2 days, followed by 20 milligrams per day for 5 days. They included all adult patients with acute ischemic stroke presenting within 48 hours of symptom onset, with END, which is defined as increase of 2 or more from presenting NIH stroke scale at 48 hours. If patient were to receive thrombolytic therapy, then they would have to wait for at least 24 hours before they can receive Argatroban. They excluded any cardiogenic cerebral embolism, and so they defined this as any patient with a history of AFib, sick sinus, mitral stenosis, any valve, or any MI within 3 months, or with a ejection fraction of less than 30%. They also excluded any patient with pre-stroke MRS score of more than 1, and also excluded severe heart dysfunction, defined as EF less than 40, kidney dysfunction, creatinine clearance less than 30, or liver dysfunction. Their primary outcome was defined as good functional outcome at 90 days using a modified Rankin scale from 0 to 3. The secondary outcomes are listed here for your reference. The ones that I care most about would probably be the favorable functional outcomes defined as MRS scale from 0 to 2, as well as the composite cardiovascular events, including cerebral vascular events, MI, and any systemic embolism. The adverse events include symptomatic intracerebral hemorrhage and parenchymal hematoma type 2. Symptomatic intracranial hemorrhage is defined as any evidence of bleeding on HCT and an increase of at least 4 points in IH stroke scales. Overall, they determined that a total of 630 patients would be required to meet power of 80% and detect a 10.4% difference in functional outcomes at day 90. So this is based on a previous observational study where they found 80% in the Argatroban group versus 69.6% in the placebo group. And they also want to compensate for 15% of non-evaluable patients. They had two different groups. They had the statistical analysis plan that's a modified intention to treat, including patient who has received at least one treatment and one efficacy evaluations. Then all outcomes were adjusted for age, sex, stroke scale at randomization, and time from index events to randomization. They then further perform a subgroup analysis where they stratify all patients into different criteria, including age, sex, stroke scale, time from symptom onset, and brief reperfusion therapy, and see if any of that had a significant impact on their primary outcome. Looking at their baseline characteristics, our patients are roughly 66-year-old and predominantly male. I do want to point your attention to the stroke scale before deterioration of roughly 3 to 4, which is, I would say, like be more a milder stroke, and then NIH scale at randomization of increase to roughly median of 8. Most of the patients were on mono antiplatelet therapy, and more patients in the control group, 34% versus 21.5% in a Argatroban group, received dual antiplatelet therapy. It's also important to note that very few patients received thrombolytics in both groups at roughly only 20%, and almost only 3 to 4 patients received endovascular treatment. Since they excluded cardioembolic stroke, the two most common stroke etiology were LAA and small vessel occlusion. For their primary outcome that is defined as MRS score of 0 to 3 at day 90, a significantly higher amount of patients in the Argatroban group had a better functional outcome compared to patients in control group. It was 80.5 versus 73.3%. After they adjusted the primary outcome for age, sex, stroke scale at randomization, and time from stroke onset, they also found a significant difference. However, I do want to point out that MRS score at 0 to 2 at day 90, there was no statistical significant difference. Some other key secondary outcomes at day 90, including a stroke or other vascular events. So we didn't see any statistical significant difference there, and also didn't really see any or not a lot of symptomatic intracranial hemorrhage as well, at roughly only 1% in each group. They then did a subgroup analysis where they looked at each of the criteria, and they found that sex has a significant interaction p-value for the primary outcome. I do also want to point out the reperfusion therapy that had no statistical significant impact on the primary outcome. From the other standpoint, their limitations that were listed in the study included having more crossover patients in the control group compared to the Argatroban group, and since it was open label designed, and they also required further validation of data in a non-Chinese population. Overall, they concluded that treatment of Argatroban and antiplatelet agents resulted in significantly greater likelihood of good functional outcome at 90 days. From my standpoint, I think that this trial was the largest randomized trial to assess Argatroban and END, because looking at the previous studies, our studies were relatively small with a not very well designed statistical analysis plan. They also looked at patient-centered outcome, which is always appreciated. From a limitation standpoint, I have a couple of things listed here. First, as I pointed out, our patients were predominantly mild to moderate stroke scale. So this makes me wonder if the same findings can be applicable to patients who had a more moderate or severe stroke scale. But I can also see where those patients might not benefit as much compared to patients who present with very mild symptoms. Since they excluded cardioembolic stroke, then our study was mostly large artery atherosclerosis and small vessel occlusion, which could impact the rate of intracerebral hemorrhage, evidenced by the fact that we had less than 1% of intracerebral hemorrhage in each patient group. Third, because of the predominantly Chinese population, this might affect the metabolism of clopidogrel. As we know, up to like 25% of Asians might have the poor metabolizer phenotype caused by two non-functional CYP219 alleles, which could definitely impact the outcome of patients who were only on antiplatelet therapy compared to those who also receive Argatroban on top of that. Fourth, the END definition definitely is very subjective because of the stroke scale defined as an increase of more than 2, and the stroke scale can vary like 1 or 2 points depending on the person who performed the scale. It's definitely a limitation of this study. Fifth, the primary outcome was conducted through a structured interview, but I do think that the MRS score can be very subjective, and this might lead to a different primary outcome. And lastly, I did not find any information on antiplatelet agents and thrombolytic therapy. Looking at the Chinese 2019 stroke guidelines, it was very likely that most of these patients were on clopidogrel and aspirin. IV alteplate was also preferred in their guidelines, so I'm assuming that's what they received, but we don't know for sure. Overall, in my opinion, Argatroban, in addition to antiplatelet therapy, may be considered in patients with acute ischemic stroke primarily due to large artery atherosclerotic or small vessel occlusion with mild to moderate stroke scale and early neurological deterioration. I do think that more data are needed to validate the safety of Argatroban use in addition to reperfusion therapy. Some of the future directions as well as future research questions that I'd like for us to kind of answer is first is the dosing. So comparing the study to the previous 4 studies that I presented to you earlier, we have different strategies. We can do either fixed dosing versus weight-based dosing versus titrate to APTT. The timing of Argatroban is definitely a critical point. So in this study, most of the patients were initiated on Argatroban roughly 24 hours from symptom onset. My question is, if they had symptom earlier than that, then are we able to start Argatroban earlier, or can we not? And all patients who had thrombolytics must wait 24 hours until they can receive Argatroban. So the same question is, if patient were to have END earlier, can they receive Argatroban earlier, or do they also have to wait for 24 hours? Next is the definition of END. Like I mentioned, the change in stroke scales definitely can be subjective, as the score can vary 1 or 2 points depending on the person who performs it. And the onset of the NIH stroke scale change. So this study used 48 hours, but we've also seen some other studies in the past that use up to 7 days. Reperfusion therapy. So only 20% of patients in this study received thrombolytics, and I want to say 1% received endovascular therapy. I wanted to see more safety data in the specific patient population who might have received thrombolytic therapy versus endovascular therapy versus both therapy. And lastly, the study was only applicable in the non-cardioembolic population, so it's a little bit difficult to extrapolate this result into the cardioembolic population. Overall, I want to thank my preceptor, Grant Morgan, for helping me with this presentation, and I'm happy to take any questions you may have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.